So let us try to understand the conduction disturbance in patients with aortic stenosis. This was a small study which was published in 1978 and clearly shows that patients who have aortic valve disease, be it aortic stenosis, aortic regurgitation, or calcified aortic sclerosis, they have some sort of conduction abnormalities, which could be a longer HV interval, longer PR and AH interval, longer PR, AH and HV interval, and longer HV interval, which clearly tells us that patients with aortic valve pathology have some sort of conduction abnormality to begin with. Let us also try to understand the relationship of the conduction system to the aortic annulus, and then only we can understand why there is requirement of pacemaker following a transcatheter aortic valve replacement. So if you can look at this slide and you can appreciate the AV node and then the bundle of His. So bundle of His goes through the membranous septum, and right where the membranous septum ends and the muscular septum begins, it divides into the left bundle and the right bundle, and it exits and comes very superficial. Again, this is a diagram which clearly shows the relationship of the conduction system to the membranous septum, and this is very important because when we deploy the aortic valve, it also anchors at the level of annulus and goes slightly into the LVOT. And you can see the depth. So this is the right coronary leaflet, a membranous septum, muscular septum, left coronary leaflet, and aortomitral continuity. So if you're doing TAVRs or if you're trying to assess the CT scan for transcatheter aortic valve replacement, we try to look at the distribution of calcium in relation to the non-coronary cusp and the right coronary cusp. So just below the right coronary and non-coronary, if there is a lot of calcification, these are the patients who are at high risk of CHP and requirement of a pacemaker, and that is because that is the place where the membranous septum goes. And if you remember the data from the first Evolute high-risk study, which was done in 2011 to 2013, the pacemaker rate was almost 30 to 35%. And that is because that self-expandable valve was deployed almost 6 to 8 mm below the aortic annulus. Now we have started deploying the valves very high, 3 millimeter. And now we can understand that the length of membranous septum varies between 2 to 6 millimeters. So if you are deeper than 6 millimeters, there is a high chance that the valve will be interfering with the conduction system, and these patients can develop complete heart block. This is a autopsy slide from a patient who had a sudden cardiac death following an aortic valve replacement, and here you can see on autopsy there is necrosis, hematoma, and compression by the prosthetic valve of his bundle. So very important for us to understand the relationship of the conduction system fibers with the aortic valve. And now, if you remember from the very first slide, if you try to do a Holter for these patients who already have aortic stenosis, 31% of patients had some sort of AV block even prior to the TAVR. Now, this is really helpful for us when we do a TAVI in a patient who has some sort of conduction abnormality. We would do a Holter upfront, 24-hour Holter, and document that these patients might be having an intermittent CHP and might be an indication for a pacemaker upfront. We can have conduction system abnormalities during TAVI straight from the guide wire, a balloon valvoplasty, and also from the aortic valve replacement. Now, this is a slide which shows the pacemaker frequency after transcatheter aortic valve replacement from 2000 and 2017. The pacemaker rate has remained almost around 10 to 12%, but this is important that the pacemaker rate before discharge has also come down, and the pacemaker rate after discharge has gone up. So what does that mean? That we are trying to evaluate these patients more carefully. In the past, there were multiple indications for a pacemaker. We were putting pacemakers for even new onset left bundle branch block. And also the pacemaker usage following TAVR was varying from country to country depending on the reimbursement and various demographic profiles. Pacer dependency post-TAVI patients who had PPM. So let us say a patient ended up getting a pacemaker. Was patient 100% dependent on pacemaker? No. So this is the slide which shows the pacemaker dependency on follow-up could be from 24% to 52%, which tells us that at 30 days to 1 year, some of these conduction abnormalities had recovered. Similarly, almost up till 4 years, only 51% of patients required pacing, which was more than 40% of time. Does pacemaker affect mortality? This is a clinical impact of conduction disturbance in transcatheter aortic valve replacement meta-analysis. So you saw in the Partner 1 trial and the Evolute high-risk trial, the pacemaker was not related to increased mortality. And that is because the average age of those patients was around 84, 85. Similarly, in partner 2 also, the average age of those patients were around 79 to 82. But if you look at the low-risk trial, the average age is 73. So the pacemaker was not probably affecting patients who were extremely high risk or octogenarian. But as we move down to the risk, pacemaker implantation is associated with increased all-cause mortality. But this is again a registry from Sweden, Swede Heart Registry, where they followed 3,420 patients from 2008 to 2018. This registry showed that the pacemaker did not affect the mortality. But let me make it very, very clear. In 2008, these patients were all octogenarians, nanogenarians. They were getting TAVI. So in that patient profile, probably pacemaker was not affected, not associated with the negative outcome. But as we move down to the low-risk patients and young patients, pacemaker is associated with poor outcomes. This was a written survey where they did a survey that when the temporary pacemaker is removed, but in a balloon expandable, self-expandable valves, but on an average, if there is a doubt that patient has developed some sort of AV block after a TAVI procedure, we'll leave pacemaker for 24 to 48 hours and review the situation after 24 to 48 hours to assess whether a patient needs a complete permanent pacemaker or not. Multivariate model for odds of permanent pacemaker implantation. I would like to bring your attention to the last column where there is bifascicular block and first degree AV block. When a patient has got a trifascicular AV block and comes to us for a TAVR, we tell him that your treatment is pacemaker plus valve replacement, and pacemaker is not a complication of such patients. And you can clearly see how pacemaker rate is so high in this group of patients. Similarly, patients with right bundle branch block. A recent study which showed that if a pacemaker patient underwent TAVI, had a baseline right bundle branch block, did not require pacemaker post-procedure, there was an increased risk of sudden cardiac death up till 1 year. And that is logical also. Left bundle is already affected with the TAVI procedure, and patient has a right bundle branch block to begin with. So such patients are at high risk of requiring a pacemaker. So very important pre-TAVR evaluation, a patient with right bundle branch block, we need to clearly explain you are at very high risk of requiring a pacemaker. Trifascicular AV block, don't send these patients home without a pacemaker. So treatment for these patients is TAVR plus pacemaker. How do we prevent pacemaker in TAVR population? We need to identify high-risk patients, early PPM if required, prolonged monitoring, decrease the recurrence. So these are certain features. It's a busy slide, but again, just to summarize, remember, right bundle branch block, trifascicular AV block, short membranous septum, calcification below the right coronary cusp and non-coronary cusp, the atrial fibrillation, elderly patients, these are the patients who are at high risk of requiring a permanent pacemaker. What is membranous septum? How do we measure? We measure it on the CT scan, and why it is important, as I highlighted in the first slide, his bundle exits the point where the membranous septum converts into a muscular septum, and that's where it divides into the left bundle and right bundle. Now, if my valve is deployed into the LV and it is below the membranous septum, high chance of conduction system abnormality. But if I deploy my valve above the membranous septum transition, there is a low probability of pacemaker. But again, let us say the membranous septum length is only 2 millimeter. That does not mean I'm going to take a chance that my valve can pop out. I'm going to educate the patient that you are at a high risk of pacemaker implantation because the length of membranous septum is only 2 millimeter. Pacemaker post-TAVR, again clearly highlighted. Presence of right bundle branch block, very important. We would optimize our procedure in such a way that this patient does not need a pacemaker, but if such patients require a pacemaker, I personally have a very low threshold of putting a pacemaker in TAVR patients with baseline right bundle branch block. There is a risk score which can help us to predict whether a patient will require pacemaker or not. History of syncope, 1 point, right bundle branch block, 2 point, QRS duration, LBB more than 140, and valve oversizing of more than 16%. The last point, it's a little bit into detail. Valve oversizing is the difference between the annulus area, the valve area divided by the annulus area. So instead of the annulus, we need to understand the valve oversizing at the level of LVOT. This oversizing could be calculated based on the diameters, based on the perimeter, and based on the area. So this is how much oversized the valve is in relation to the LVOT. More the oversize, more the pressure on the conduction system, higher the chance of pacemaker. So this is again a busy slide, but it evaluated the utility of 30-day continuous ambulatory monitoring to identify patients with delayed occurrence of AV block after transcatheter valve replacement. Now, let us say you have a patient with right bundle branch block. You ended up doing a TAVI. Patient does not require a pacemaker after the procedure. You send the patient home. So there is no harm in doing a prolonged monitoring, because this study showed that 7% of patients developed symptomatic third-degree AV block and require a pacemaker. So such patients can be closely monitored for a month. So this was again a slide, predictors of permanent pacemaker after transaortic valve replacement. As I said, just remember three things. One is right bundle branch block, depth of implantation, calcification, and the fourth one is oversizing. So how do we manage conduction system abnormality associated with TAVR? A TAVR candidate, pre-op evaluation is very important. We can do a Holter monitoring and then procedural telemetry and 12-lead ECG at the end of procedure. No ECG changes, no pre-existing right bundle branch block. The temporary pacemaker is removed within 24 hours. No ECG pre-existing right bundle branch block, but the ECG remains same as what it was before. Leave the pacemaker for 24 hours and evaluate. A patient who has got a high degree AV block, a CHB, you can leave the temporary pacemaker for 24 hours, evaluate. Any doubt, go ahead and put a permanent pacemaker. How do we reduce the pacemaker requirement during the procedure? There's something called cusp overlap technique, where we overlap the left and the right and keep the non on one side. And this way, technically it helps us to visualize the LVOT in a longer axis, and we are able to deploy the valve very high and does not interact with the LVOT. 82-year-old female, severe AS, valve area of 0.4, mean gradient of 64, sinus rhythm, right bundle branch block. This is a little technical, but I'm going to share with you. You can see this is the aortogram. On the left side, you can see the non, right, and left cusp, and on the right side, you can see how the non is on one side and right and left are overlapped. So we can see LVOT elongated, and the valve was deployed at the right depth, 0 millimeters. So if you can see the final angiogram, and you can see the valve is almost like a surgical valve. It is not into the LVOT, no paravalvular leak, and no requirement of pacemaker in presence of right bundle branch block. But I did a Holter before discharge to make sure there is no CHB. Similarly, for a balloon expandable, this is an Edwards Sapien 3 valve where a patient has got a right bundle branch block. We do in a cusp overlap view where the non is one side, the right and left are overlapped, and you can see the final angiogram, how the valve is right at the annulus, not at all into the LVOT, no paravalvular leak, and no pacemaker requirement post-valve deployment. I have published my own outcome as a single operator, single center experience. This is the first 105 patients where the pacemaker rate was 5.7%, and patients who got pacemaker rate, number 1 was 84, core valve, this is the first generation valve. Number 2 patient, 81, LBB with first degree. Number 3, atrial fibrillation. Number 4 patient already had a trifascicular AV block. Number 5 patient, trifascicular AV block. Number 6 patient, trifascicular AV block. This is our outcome we compared with the standard trials. Of 200 patients which we have completed, MyoValve Evolute Sapien. I'm going to come to the pacemaker data. The pacemaker rate with MyoValve was 1%, with Sapien 3, 3%, and Evolute 4%. Conclusion. Low risk, we need to identify low risk patients, no right bundle branch block, and no need for pacing for a high degree AV block after TAVR. Recommendation, remove temporary wire at the conclusion, discharge with live monitoring if 2 minor risk factors are present. If pacing is needed or high degree AV block is noted at any point, upgrade this patient to high risk. Now let us see high risk. Let's just focus on the high risk patients. Right bundle branch block and need for pacing for a high degree AV block anytime post TAVR, put a pacemaker. Don't even think about it. No right bundle branch block and need for pacing or a high degree AV block anytime post TAVR. Reassess the need for pacing at 24 hours. Implant at 24 hours if 1 or more minor risk factors are still require pacing. Implant at 48 hours still requiring pacing. Discharge with live monitor if not implanted. So to summarize this slide, again, just remember, if patient has a right bundle branch block, develops a CHB post TAVR, put a pacemaker. Right bundle branch block does not develop a CHB post TAVR, monitor for 24 hours, and do a Holter at time of discharge. Thank you very much for your kind attention.